Hello, everyone. Welcome to today's webinar. It's World Sepsis Day today, and we are very excited to be here to present challenges in sepsis, diagnostics, and patient management. I'm Dr. Jordan Cardinal, the U.S. Region Microbiology Medical Science Liaison at BD in our Life Sciences Integrated Diagnostic Solutions Business Unit. I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by BD. To learn more, feel free to visit bd.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well. We've already gotten one question this morning that I wanted to address here in the introduction. We will plan on adding CE credits for the on-demand portion of this program. They aren't applied to this live session yet. It's my pleasure now to welcome our speaker today, Dr. Pat Murray. Dr. Pat Murray received his microbiology Ph.D. at UCLA before going on to postgraduate training in clinical micro at Mayo Clinic in Rochester. He was the director of the Clinical Microbiology Lab at Barnes-Jewish Hospital and professor of medicine and pathology at Washington University from 1976 to 1999. In 1999, he joined the faculty of the University of Maryland School of Medicine, and in 2001, soon after, he accepted the position of Senior Scientist and Chief of Microbiology at the National Institutes of Health. In July 2011, he retired from the NIH and accepted a position at BD Diagnostics as Vice President and Worldwide Scientific Affairs, and that's where I had the pleasure to cross paths with him. He did retire to our dismay last year in 2021. He is still a fellow of the American Academy of Microbiology and IDSA, and also a member of the CLSI Consensus Committee for Antimicrobial Susceptibility Standards. He's the former chairman of the American Board of Medical Microbiology, former editor-in-chief for the ASM Manual of Clinical Microbiology, and former editor of Journal of Clinical Microbiology. He still currently serves on numerous editorial boards. He's authored more than 275 research articles and 20 books. He's also the recipient of numerous awards through his robust career and his contributions to our field in patient care research, leadership, and all of his achievements. It's our privilege to hear from him today and learn more about sepsis from the perspective of diagnostics. So thank you, Dr. Murray.
Thank you, Jordan, for your kind comments. As Jordan mentioned, I retired at the beginning of this year from Becton Dickinson. So it was very nice that they've invited me back to give this presentation. So let me hit the right button. Because I retired, they are paying me an honorarium for my presentation, but I frankly would have done this anyway, because I think today is a very important day. I think what I'd like to do is look at sepsis and try to put it in a little bit of a different perspective. Many in the audience come from a diagnostic field or come from medicine where they rely heavily on diagnostics. So I think it's important to understand the value of diagnostics and the limitations of diagnostics. I believe it's important also to start with some definitions. So when we talk about bacteremia or fungemia, we're talking about the presence of bacteria or fungi in the blood. A bloodstream infection then is a positive blood culture in a patient with systemic signs of infection, and that may either be primary, that is from the blood vessels themselves, or secondary from an infection such as a urinary tract infection or pneumonia. Sepsis is a life-threatening organ dysfunction caused by the dysregulation of the host's response to infection. In other words, we overreact to the infection and it creates some damage to one or more organs. And if it's multiple organs, we define that as septic shock. Now, there's some important facts that I've listed here about sepsis. I think the important thing to keep in mind is that it's common. 49 million cases have been reported each year with about 11 million deaths. So it's a common disease with a high mortality rate. It's the leading cause of mortality and critical illness worldwide. And when we look at hospital mortality, patients with sepsis have a 25 to 30% risk of not surviving that infection. There's a variety of risk factors that are responsible for that, but one in particular that I want to point out is that there's a twofold increase in mortality when the wrong antibiotics are given. And why is that important? Because selecting the appropriate antibiotic requires good diagnostic tests. And so that underscores the value of diagnostics. The last point, we don't like to think always in terms of medical illnesses and the cost of those medical illnesses, but I think it is important to recognize that sepsis is the leading cost in hospitalized patients in the United States, attributing for more than $62 billion of expenses each year. So not only is this a deadly disease, it's a very costly disease. Now, in 2021, guidelines for managing sepsis were issued. This is an update from previous guidelines. On the surface, this is very similar to what had been said before. We want to be able to identify septic patients as early as possible, or at least have a suspicion they're septic. Use markers like L-lactate to help ensure that early identification. Cultures become very important, not just blood cultures, but cultures of other potential sites of infection. So we'll talk about that for a little bit. Antibiotics obviously are important in an infected patient. We want to make sure we give them the appropriate antibiotics. And then fluids are necessary to be able to, one of the problems with sepsis is that there's a lack of diffusion of fluids into the organs, which causes the organs then to fail. And so fluids is an important component for managing septic patients. I'm going to, in the next two slides, I'm going to quote directly from the 2021 sepsis guidelines. To start off, we recommend that appropriate routine microbiologic cultures, including blood cultures, should be obtained before starting antimicrobial therapy in patients with suspected sepsis and septic shock, if this results in no substantial delay in the start of antimicrobials. What we do know is that anywhere from 28 to 63% of patients receive antibiotics before those cultures are collected. And as I'll show on a later slide, this has a direct effect on the success of those cultures. And we must weigh the use of cultures and diagnostics and treatment, and to say that we don't want to delay key therapy. From the same guidelines, they actually became much more specific than what we had before. So for adults with possible septic shock or a high likelihood for sepsis, the recommendation is to administer antimicrobials immediately, ideally within 1 hour of recognition. So if we want to give cultures before antibiotics, this is a challenge for us to be able to collect the cultures in a timely way. For adults with possible sepsis without shock, we recommend rapid assessment of the likelihood of infectious versus non-infectious causes and a time-limited course of rapid investigation, and if the concern for infection persists, the administration of antimicrobials within 3 hours from the time sepsis was first recognized. So without septic shock, the recommendation is to wait up to 3 hours before antibiotics are administered. And finally, for adults with a low likelihood of infection and without shock, we suggest deferring antimicrobials while continuing to closely monitor the patient. So this is a balance between diagnostics, treatment, and really antimicrobial stewardship to not overutilize antibiotics when they're not necessary. So some of the diagnostic challenges, and most of my presentation, I'm going to talk about these challenges. Our challenge is to collect the microbiology specimen, but the question is, what specimens have the highest diagnostic yield? What's the most common sources of sepsis? And what are the challenges in collecting the microbiology specimens? So if we look at the broader picture, I think it's important that if you look at a population of septic patients, anywhere from 20% to 54% will have documented bloodstream infections. That is, we have a positive blood culture. Now, if you think about it, we're missing as many as 80% of the patients with sepsis with our blood cultures. And there's reasons for that, and that's what I'll explore in the next series of slides. But it's also important to look for other types of cultures that can help guide our management of these septic patients. Anywhere from 16 to 30% of patients with sepsis will have other positive cultures, like a respiratory culture or a urine culture. So it's important to collect the right specimens there. But still keep in mind, 40% of the patients have culture negative diagnostics. So our challenge is, how do we reduce that 40%? What are the opportunities to improve the blood cultures and the other diagnostic tests that we perform? Now, sepsis can be caused by infections with a variety of organisms. Bacteria and yeast are what we look for in blood cultures, and for most of our cultures, that's what we look for. Filamentous fungi, viruses, and parasites, we don't look for unless we specifically suspect those infections. So there are causes of sepsis that unless we have a high index of suspicion, we're not going to be able to detect them. Infections associated with sepsis include urinary tract infections, which is the most common, lower respiratory tract infections like pneumonia, which is the second most common, and then other types of infections like meningitis, intra-abdominal infections, skin and soft tissue infections, and intravascular or catheter-related infections. Now, if we look at each one of these types of specimens, I'm just going to give an overview of what I think are the challenges. For urinary tract infections, what we find is about 50% of patients have fewer than 10 to the 5 organisms per milliliter of urine. So in many patients, they have very low numbers of organisms in the urine. And in a septic patient, they don't produce much urine. That is one of the characteristics of sepsis. And so it's going to be challenging to get the right specimen in order to make the diagnosis. The number of colony-forming units in that specimen is influenced by the pathogen, the time of day, in other words, how long has the urine been in the bladder, the frequency of voiding, the patient's hydration, prior antibiotic therapy. All of those can reduce those positive urine cultures. Contamination with urethral can also complicate the interpretation of that culture. For lower respiratory tract infections, many times a fastidious pathogen is responsible, and unless we suspect it, we won't detect it. We can have viral pathogens. We saw this with the SARS-CoV-2 pandemic that are responsible for sepsis. And it can be, again, the specimen can be contaminated during collection. Meningitis, this is an invasive specimen. The collection is an invasive procedure. If the patient has been pre-treated with antibiotics, then the success of a spinal fluid culture is quite low. And many cases are caused by viruses or even fungal pathogens like Cryptococcus. And so unless we suspect that, we're not going to do the right diagnostic test. Intra-abdominal infections are an invasive specimen. It's usually caused by a mixture of aerobic and anaerobic organisms as well as yeast. And skin and soft tissue infections is potentially an invasive collection. We have to make sure we collect that specimen at the site of where the pathogen is located, which sometimes is a challenge. For intravascular infections or catheter-related infections, many pathogens are not recovered in the blood culture. That can include fastidious and slow-growing bacteria, filamentous fungi, and viruses. So we would expect, unfortunately, in those cases, the blood culture is not going to be very helpful. Care is required to avoid contamination of the cultures. The majority of bacterial infections are caused by less than one organism per milliliter of blood, because frequently the bacteria are diluted in a large volume of blood in the patient or removed through the filtering system in the human body. Therefore, a positive blood culture is directly related to how much blood is cultured. And again, I'll share some specific data to support this concept. Positive blood cultures are also related to the culture media that's used. And again, I'll explore this in a second. And finally, the presence of antibiotics reduce the yield of a culture. The two most important variables for a successful blood culture is the volume of blood that's collected and the culture media. If we focus on optimizing those two variables, we're going to have significant better success with obtaining a positive blood culture. Now, what I'd like to do is look at some pre-analytical concepts and put all this in perspective. So start off with a few important points. Most septic patients have less than one organism per milliliter of blood. And I'll say that again, most septic patients have less than one organism per milliliter of blood. On average, most blood culture bottles are filled with less than 25% of the recommended 10 mLs per bottle. So most bottles are underfilled. Numerous clinical studies have demonstrated that if the blood culture bottles were filled properly, the proportion of positive blood cultures would be increased by 40 to 50%. And finally, clinical studies have demonstrated that 2 to 3 blood cultures, each consisting of 2 bottles, should be inoculated for optimum yield. And again, let me share with you the data that supports these comments. The first is a study that I pulled together 5 studies that have looked at the question, how many bacteria are circulated in the bloodstream when you collect that culture? And every study came up with the same conclusion. There is a significant proportion of blood cultures that have less than one organism per milliliter of blood. And this is true whether it's gram-positive organisms like Staph aureus, gram-negative organisms like E. coli or Pseudomonas, or yeast. All of these cultures had fewer, or many of these cultures had fewer than one organism per milliliter. Now, what does that mean? A series of 7 studies here actually looked and asked the question, are the bottles filled properly? In other words, they looked at all of the blood culture bottles they were receiving in their laboratory and said, how many of these are properly filled? And what we see is the vast majority of them are not properly filled. As an example, a 2018 study by Cantor, they found that 20% of the adult bottles were properly filled. The last 2 studies cited in this slide by Chang and Kahari actually reported the amount of blood that's being put into the bottles, and generally is 2 to 3 milliliters of blood per bottle. Not the 10 mLs that's recommended, only 25%. Now, if most patients have relatively few organisms in the bloodstream and most bottles are underfilled, what is the impact of that? And in this series of studies, that's what they looked at. And I'll cite, all the studies have the same conclusion, but let me just look at the Patel study that was reported in 2011. In this study, they collected 6 bottles, 3 cultures with 2 bottles each bottle with 10 mLs of blood. And then they looked at the first bottle with 10 mLs compared to the first 2 bottles. And they found that with going from 10 mLs to 20 mLs, they had a 25% increase in positive cultures. If they went from 10 mLs to 3 bottles with a total of 30 mLs of blood, it was a 35% increase. Going to 4 bottles or 2 sets of 2 bottles, it was a 47 or 48% increase. And if a full 3 cultures were collected, there was a 64% increase in positive blood cultures. So to pose the question, if we're going to do a blood culture, why not optimize that blood culture? Even if it's a single blood culture, optimize the success of getting a positive culture with that. And that's what these studies demonstrate by improving the amount of blood that's being cultured. Now, just to summarize, there's relatively few organisms circulating in the blood of patients with infections, so a large volume of blood must be cultured to get maximum number of positive cultures. The blood cultures are consistently underfilled, so many cultures are negative. So if we focus on how to improve what we do, the first thing is to focus on how do we get the right amount of blood collected, even for that first blood culture. And then finally, we should focus on maximizing the value of blood cultures by following our rule 10 by 2 by 2. That is 10 mLs of blood per bottle, 2 bottles per culture, and 2 cultures per patient. If we follow these guidelines, our success in getting positive blood cultures will be significantly improved for these septic patients. This was a study I found really very interesting. It was reported in 2019, and they directly addressed the question, what is the effect of antibiotics on positive blood cultures? Now, the interesting thing is for this study, they were using resin bottles, which are designed to remove the presence of antibiotics. Despite that, we see a significant impact when antibiotics are administered. The red line here is at 15% of the bottles are positive. If you look at before antibiotics are administered, or even within an hour after administration, in general, between 25 and 30% of the blood cultures were positive. But for the same patient population, after the antibiotics had been administered, and even up to 24 hours later, there was a 50% reduction in positive blood cultures. So even with the value of resins, we still see that there is a challenge in getting positive blood cultures in patients that have received antibiotics. The other point that I made at the beginning is the importance of media. And there's 4 principles that I want you to keep in mind. The first is no culture medium will support the growth of all organisms. The second is that resin media removes both antibiotics, but it also removes important growth nutrients. The third point is that specialized media can enhance the recovery of selected pathogens. And the fourth point is that a combination of aerobic and anaerobic media is critical for blood cultures performed with adult patients. Now, again, let me give a little bit of justification for each of these. The first principle is that no cultural media will support all organisms. It's really straightforward. Strict aerobic organisms don't grow in the anaerobic bottle. Strict anaerobic organisms don't grow in the aerobic bottle. Microaerophilic and fastidious organisms grow poorly in both of these bottles. And what we see is that the combination of media will enhance the overall recovery of pathogens. So it becomes important to use multiple types of media. The second is that resins remove both antibiotics and growth nutrients. BD introduced resin media 40 years ago. And what we found is that it is important for removing selected antibiotics, not all antibiotics, as the earlier slide demonstrated, but it is important to remove many of the antibiotics. But we also know that it removes nutrients, anticoagulants, and other required growth factors. And so it's important in the manufacturing of the media to have the right complement of nutrients in order to overcome this adverse effect of the resins. I think it's important to just keep in mind that the most powerful resins, that is the ones that remove the most antibiotics, are not necessarily the best resins, because they're also are effectively removing many of the nutrients that are important. Specialized media is also important. There's media that's been designed for pediatric patients, and it's not just media in a pediatric sized bottle, it's actually specific formulations for pediatric patients to enhance the recovery of selected pediatric pathogens. We've also seen fungal media, and the value of that is decreasing the time to detection and improving the overall detection of selected fungi. Candida glabrata and Cryptococcus neoformans are probably the two best examples of this. Lytic media turns out to be significantly, how do I say this, is particularly important because what it does is it lyses the blood cells, provides more nutrients for the organisms to grow, more essentially better growth condition, and it decreases the background noise of the blood cell metabolism, so you get earlier detection of organisms when they grow in the lytic media. So it's an important complement to what we use with other types of media. And finally, the combination of aerobic and anaerobic media is important for adult patients. A number of studies have looked at the impact of anaerobic media, and we see there is improved recovery of organisms. Many of these are microaerophilic organisms like the Enterobacteriaceae, like E. coli, or like Staphylococcus aureus and so forth. So it's this combination of different media that really enhance our overall performance. If we keep in mind then the principles of a positive blood culture, relatively few organisms circulate in the bloodstream of a septic patient. Culturing an increased volume of blood increases the likelihood of obtaining a positive culture. And the use of multiple types of culture media, such as aerobic media, anaerobic media, resin media, and lytic media, is required to optimize the value of that blood culture. So an important question remains, what can we do to optimize blood collection? In other words, most of what I've talked about is the pre-analytical stuff, collecting the right volume of blood, putting in the right blood culture media in order to optimize the efforts that occur in the laboratory. But how can we improve this? Well, one of the issues is the decreased contamination of blood cultures. And that starts with the disinfectant that's used. This nice study that I've cited here looked at the impact of tincture of iodine compared with chlorhexidine alcohol. The important point is that chlorhexidine alcohol is able to work much more rapidly than tincture of iodine. And if you listen to the recommendations for collecting blood cultures and then you look at the practice, frequently when iodine is used, it's not left in contact with the skin for a sufficient period of time, and so you result in contaminated blood cultures. This study compared 2 minutes with tincture of iodine with 15 seconds of chlorhexidine, which works much faster, and we see a significant reduction in contaminated cultures. In addition to the disinfectants, it's important to use standardized collection protocols and kits that standardize this collection of these important specimens. If available, a dedicated phlebotomy team has been demonstrated to improve the overall quality of specimens that are collected. Education, training, monitoring, and feedback to identify when you have a problem and help correct that problem. All of these factors will improve the ability to collect the appropriate blood culture and have it not contaminated with the skin microflora. The other thing, and I'm just going to use an example here, but it's really a broader principle, and that is look for innovative ways to do the standard procedures. Now, I talked about specimen collection and how you can take that combination of trained individuals to collect the specimen using the standardized protocol and kit, education, monitoring, and feedback. All of those can improve the recovery. But you think about other ways you can do it. I'm just using one example, and this is with the UltraTouch needle that's been developed by Becton Dickinson. And the difference between this and a regular needle is that although the outer diameter is the same for, say, this and a traditional needle, the inner diameter is much larger because it's a thinner wall. The practical aspects of this, if you look at a 23 gauge needle, there actually is a 40% increase in the size of the opening for that needle when the thin wall needle. If you looked at a 25 gauge needle, there's a 33% increase in the opening. Now, what does that mean? You have a larger opening for blood to flow through, so you should be able to collect blood more rapidly with the thin wall needles than with a traditional needle. And again, frequently, if you have a septic patient, many things are happening very rapidly. You want to be able to quickly collect your cultures, and so then antibiotics can be given. So this is one aspect that helps improve the ability to collect the appropriate volume of blood in a timely way. So let me just conclude and say, recognizing that each clinical situation can pose challenges and economic conditions can limit the availability of diagnostics, we want to make each blood culture optimal. I've traveled many countries in the world, and I know there are challenges to collecting what the ideal volume of blood is, or the ideal number of cultures. So what I'm going to leave you with is the fact that you understand the limitations of diagnostics. You understand the impact of underfilling bottles or not collecting the right number of bottles. But what you have to do is, even if you collect a single 2-bottle set, make it the best set you can collect and optimize the percent positive blood cultures from each single set that you collect. And I think if we do that, then we're going to see a significant improvement in the diagnosis of sepsis for these patients. So let me stop there. I'll turn this over to Jordan and have her presentation. Jordan?
Thank you so much, Dr. That was such a great breakdown of a lot of the diagnostic challenges we're faced with in sepsis patients. And it's very important to recognize so many of them are modifiable. So from the phlebotomist's hands and the nurse's hands, we can really impact the quality of our cultures. So I want to zoom out and expand the conversation to the treatment challenges, the downstream treatment challenges that can come up in sepsis patients as well. I will fill you in. My background is in emergency medicine and critical care pharmacy. So I will be referencing a lot of my experience that I have firsthand as I staff emergency departments and ICUs. So we know diagnostics and treatment decisions go hand in hand. It's often quoted that 70% of clinical decisions are based on information that is derived from laboratory test results. So these results that Dr. Murray was pointing out, areas where we can improve and ensure the quality of those results. These objective results that come from the lab are especially important for our sepsis patients. We know the presentation of sepsis is quite nonspecific. And so any objective, clear results we can get for the lab really do impact clinical decisions in a profound way. So I mentioned sepsis is a particular challenge in terms of its nonspecific presentation. Therefore, clinicians often have to use a multifaceted approach to ensuring their diagnosis of sepsis is correct. That includes looking at the patient's history, doing a thorough physical exam, using some of the tools we have to combine some of the laboratory findings and vitals to see if they're meeting septic criteria. Using biomarkers is becoming more and more accepted as a tool to try to predict our confidence level if this patient has sepsis, as well as the tried and true cultures. We know cultures are still mainstay of treatment and one of the ways we can most confidently identify a causative infection. A lot of these approaches to diagnosis, though, have come with their own challenges. The first three here, the patient history physical exam and calculation of our SIRS or QSOFA scores, still lead us with a quite broad differential, so they lack some specificity. That's also true with our biomarker tests. More and more diagnostic companies are combining biomarkers in different ways to see if we can increase the specificity of the confidence they can give us that this patient is truly sepsis and declining from a causative infection. And again, we talked about cultures being one of the mainstays of treatment here and really helping us to objectively identify an infection and the causative organism. Of course, Dr. Murray talked about a lot of the modifiable factors that can impact the quality of cultures. So there are some weaknesses with cultures we can tackle. First, cultures take time. So trying to find innovative ways to minimize your turnaround time is always important. And then also they're susceptible to sample collection variability. So ensuring phlebotomy technique and nursing training is up to speed, and whoever's collecting the cultures understand the risks if the cultures aren't obtained appropriately. So beyond diagnostic challenges, there's also treatment challenges, and I want to bring the patients we're impacting to the forefront of this conversation. So some of the treatment challenges that come with sepsis is not every sepsis patient looks the same. It could be a young patient in their teens with a past medical history of IV drug abuse presenting with a disseminated abscess that finally made it into the bloodstream. Or it could be our older patient who's been through 3 rounds of chemotherapy, is severely immunocompromised and struggling with the opportunistic infection. So every sepsis patient can look quite different. So each needs to be approached in a patient-specific manner where we're taking into consideration the risks and benefits of every decision we make, customized for that patient. To inform those decisions, of course, it's always important to keep in your mind what is actually going to impact this patient's outcomes. And there's so much literature in this space around sepsis that I want to take us through quickly today. On rounds, it's often the literature that shows impacts on mortality, increases in mortality, that we reference the most and give the most weight. So I did want to also add to this conversation some of the known risk factors for death in sepsis that we already have a good grasp of. One is increasing age. Of course, that's non-modifiable. Immune dysfunction is non-modifiable unless it's a chronic disease such as uncontrolled diabetes. We could assist the patient there. But for the most part, if you need a immunocompromising antibiotic therapy due to a past transplant, for example, we can't really modify that. Delays in receipt of effective antimicrobials is linked to impacting mortality in these patients, as well as associated lung injury. So for purposes of today, I really want to bring attention to this modifiable bullet. Delays in receipt of effective antimicrobials is truly life-saving, and it's a very time-sensitive matter. So the Surviving Sepsis Guidelines, published and updated at the end of last year, really help us break down the whole picture of what's going to impact outcomes to inform our patient-specific approaches. They start by talking about performance improvement programs, and they emphasize the importance of always reevaluating your processes, your techniques, your phlebotomy teams and your pre-analytical, as well as your teams in the micro lab, our knowledge of proper technique and culture processing. They do talk about it, though, in a more broad approach of general sepsis bundles, which Dr. Murray took us through. But I do want to emphasize cultures here. I will tell you, practicing in emergency departments, we focus on a decompensating sepsis patient and the time sensitivity of antibiotics. But I have noticed a lack of focus on timing of cultures, technique around those cultures, and setting ourselves up for downstream success to be able to make decisions off of accurate and efficiently drawn cultures. So that should be something we're all aware of, I think, from a multidisciplinary approach, so we can prioritize cultures and then hang antibiotics in a timely manner. The new guidelines actually do emphasize if there's ambiguity in the patient, so it's not a clearly septic shock patient with a clear history of infection, and we know this is a decline due to infection, even putting more weight on the importance of drawing cultures and drawing them appropriately and thoroughly before getting antibiotics on board. As Pat's slide showed, we have up to 3 hours in those more ambiguous, not clearly septic shock patients. So this can impact mortality, and you can see the odds ratio here on the slide can impact mortality by up to 40%. So sepsis is a time-sensitive matter, and here I spell out some of the other time-sensitive manners we come across in our emergency departments, including major traumas, STEMIs, and strokes. We do want to encourage sepsis to begin to be thought about in this way. Minimizing your time to antibiotics in these patients, especially if they're really declined, is crucial. But doing it in a thoughtful way that we're not ignoring the importance of cultures and setting ourselves up for success of optimizing those antibiotics down the line. So appropriate cultures, what is an appropriate culture? Often we think about the laboratory the culture is being sent to and some of the tools that are being used in that lab. I have pictured here a continuous blood culture monitoring system, as well as software that can be used to relay those results. But as Dr. Murray so eloquently spelled out, pre-analytical factors and decisions could influence the quality of our cultures just as much. And so proper antisepsis prior to obtaining a blood culture, proper selection of a needle and use of a needle and transfer device system, as well as proper selection of media are crucial. And then, of course, I've emphasized this a lot. I'm a pharmacist, so I'm very passionate about this concept, but time to appropriate empiric antibiotics can be life-saving. We know if empiric antibiotics are started early and they're correct, if it's a really septic patient, so declined septic shock with hemodynamic instability, some studies have shown mortality risk decreases by up to 7% every hour. Other studies where they're less severe have shown increases closer to 1% per hour. Either way, these are impacting risk of death, which is huge. Also, the sooner we can get antibiotics on, the sooner we can try to prevent further nosocomial spread between our patients and introducing more organisms into the hospital. If incorrect, of course, mortality risk is going to continue to increase, which is very concerning for, again, those more progressed septic shock patients. And risk of nosocomial spread remains because you're not covering the organism. And lastly, you're exposing that patient to antibiotics where their organisms can actually and I'm sorry, I don't know if that slide was being pushed to you, but where you're exposing patients to antibiotics so their organisms have a chance to begin to learn and to develop resistance. So how are we doing with our empiric antibiotic selection? There's some recent literature that shows we need to be paying more attention to this, as inappropriate antibiotic use has actually gone up during the pandemic. You can see here with 3 waves of COVID, the first on the left being Epsilon, then Delta, then Omicron. With each peak, we see significant increases in 3rd and 4th generation cephalosporins, as well as macrolides. And this is very understandable because I will tell you a respiratory decline that came into the hospital over the past few years. It's hard to justify not putting on antibiotics because it's hard to differentiate viral from bacterial pneumonia. But the appropriateness, this still should be done thoughtfully and the appropriateness assessed. So there's been some internal research done actually by some colleagues here at BD that I'm really excited to share with you today. Special thanks to Dr. Vikas Gupta and Calvin Yu. But if I can bring your attention to the table here on the right and the 4th row down that's highlighted in blue, I want to point out our COVID patients here in this row. If they had a co-bacterial infection that didn't have resistance, so it's one of our common pneumonia organisms, we were getting empiric therapies right about 75% of the time. If any antimicrobial resistance was present in that patient, our appropriate empiric antibiotic decisions went down to about 60% of the time, or 65%. 63. And if they had multi-drug resistance, antimicrobial resistance, we were about 50-50 in our accurate guesses on empiric antibiotic therapy. So it's so important to not only start antibiotics early, but really do it thoughtfully, because if we're not doing it thoughtfully, we could be worsening AMR and we aren't decreasing that patient's risk of mortality. So of course, your risk of getting it wrong increases with AMR, as that data shows. But how can we fix this? How can we get these as correct as possible? Well, straight off the bat with empiric therapy, we're never going to get it perfect 100%, but it's super important to make sure we're diving into the patient's past medical history, past cultures, and trying to inform those antibiotic decisions. And then fortunately, the point of our slides today, and I'm sorry, let me make sure I'm pushing this to you. Sorry, so I was saying, how can we fix this and get 100% of our empiric antibiotic decisions correct? And so besides diving into their past medical histories, we have tools, and we have tools that we can use in a more optimal way. And I want to encourage us bringing more and more attention to the quality and use of our diagnostics. This will take some collaboration with our pre-analytical teams, but also our decision-making teams on the back end once these results are reported. So if pharmacy or the ID teams can respond more quickly to the initial gram stain, we are impacting potentially mortality. If the teams can respond quickly to that first ID off, let's say they use moldy, we are impacting mortality. And then of course, being able to have full confidence in our antimicrobial susceptibility test to ensure the most accurate and narrow therapy, we are possibly impacting mortality in these sepsis patients. So in summary, I just thought it was really helpful to break down these guidelines and bring our patients to the forefront of this conversation and the importance of diagnostics. We should always be trying to implement new performance improvement programs around our diagnostics to ensure we're always optimizing our technique and our knowledge of the consequences of if our technique isn't appropriate. We need to make sure we're always acting fast. We need to ensure our cultures are done appropriately. This in and of itself has shown mortality benefit. Ensure we are optimizing our instrumentation and really trying to optimize turnaround time as well as quality and positivity rates off of our cultures. And then lastly, that we're relaying the results to the treatment decision teams in a timely manner and that they are responding in a timely manner. So this really is an interdisciplinary effort. And I want to ask you today, how can we close the gap between our pre-analytical teams, our laboratory personnel, and our treatment teams? Because this is a multifaceted issue that we want to bring more attention to diagnostics. And really, again, this is all with the goal to improve sepsis patient outcomes. And I want to leave today with proposing a question to you, whether your role is down in the microbiology lab, usually that's down, but sometimes it's up, and or if you're the pre-analytical team, so nursing and phlebotomy, and or part of the antibiotic decision-making teams, what can you do to narrow these gaps between our teams and ensure we're all aware of diagnostic optimization opportunities in our hospitals that will impact sepsis patient outcomes? So thank you so much for your time today. And again, thank you, Dr. Murray, so much for your breakdown of some of the diagnostic challenges and approaches we can take. We'll go ahead and start our Q&A portion of this presentation. There's Dr. Murray. Perfect. Thank you. So if you have questions and you're attending right now, if you'd like to ask them now, please do so. Again, just click on the Ask a Question box located on the far left of your screen, and we'll answer as many of your questions as we have time for. So we're looking forward to hearing your questions, and we'll get started now. So first question for you, Dr. Murray, we'd love to pick your brain on, you mentioned the variability that can exist in positivity rates we obtain from blood cultures as well as contamination rates. So do you have advice on how we can assess the significance of a positive blood culture?
So it's an interesting question. And maybe because of my age, I can cite literature that's probably published before some of you were born. But in the 1990s, there were some really very nice studies that I think are still relevant today. And they were performed by Mel Weinstein, Barth Reller, and a group. And what they did, it was two separate studies, and each one looked at 500 patients with positive blood cultures. And then they made a clinical assessment of the significance of the positive isolates. And probably it shouldn't be a surprise, but if you looked at the recovery of Staph aureus in a blood culture, about 75% of those patients turned out to have significant isolates. And at that time, and again, remember, this is in the 1990s, less than 10% of the patients with coagulase negative staphylococci had significant cultures. I think that's changed dramatically in our hospitals today with use of IV lines and prosthetic devices such as heart valves and so forth. So the percent significant coagulase negative bacteremias is probably higher than what it was in that study. If you looked at gram-negative bacteria, the E. coli, Klebsiella, all of the gram-negatives, almost all of those were significant, except for some of the non-fermenters, some Pseudomonas species other than the ruginosa. But in general, if it's a gram-negative, it's going to be clinically significant. The same was true for yeast infections. If you isolate yeast in blood, that's almost always clinically significant. So I think we can use that as a general guideline, but it's always a clinical assessment when you look at the patient, and you have to make the physician who's taking care of that patient has to balance that with the isolate that you have. I think in a microbiology laboratory, because we have the ability to identify organisms much better than what we could historically, moving from biochemical testing to the use of MALDI-TOF, we're able to identify organisms that many times the physician hasn't heard of before. And so one of our responsibilities is to understand the significance of that organism, its association with infections, and be able to educate our physicians about that. So again, a challenge for the laboratories now that we can identify organisms, maybe a more sophisticated way than what we've done historically.
Absolutely, and another opportunity to collaborate between the lab and the decision-making team to ensure it's a very informed decision. So thank you for that breakdown. We talked about the importance of minimizing turnaround times and ensuring both accuracy but also efficiency for cultures. So where have you seen in your patient care experience the most significant delays in being able to relay positive results to the treatment team?
You know, from a microbiology laboratory perspective, we've always focused on how fast does the organism grow in the incubator. And we try to understand the significance of 1 hour faster growth in one type of culture system versus another. And I think that's important to be aware of that, but that's not where the problems are. The problems start in taking that blood culture that's collected on the floor and getting it into the laboratory. And the studies that have looked at this have shown that there are delays up to 15 hours, particularly in emergency departments and in highly busy areas like ICUs. Those cultures may be collected, but if they sit there in a nurse's station and don't get delivered to the laboratory, we have a significant problem. Even under routine conditions, there's typically a 3, 4, 5 hour delay before the cultures get there. And if they're collected in the evening, it may be a number of hours before it's actually put into the incubator. The other area where I see significant delays is the blood culture signals positive in your instrument, but it's not taken out of the instrument and worked up. Many times the laboratory don't prioritize that positive blood cultures. Now, in some cases, it's because a significant proportion become positive when nobody's in the laboratory, and that's something that should be addressed for those laboratories. How can they prioritize that positive that comes up at 3 in the morning? And in other cases, they prioritize that we will look at and work up that positive blood cultures at certain periods during the day. They don't do it when it becomes positive, but there may be a delay of 3, 4, 5, 6 hours before it's worked up. So if we really want to reduce the amount of time it takes, we have to focus on first understanding where the delays are in getting the bottles into the laboratory, and then where are the delays in the laboratory prioritizing the workup and reporting of those positive cultures. I think if we master that, then we can look at, I think, what much less significant delays, such as how long does it take for that bottle to grow in the incubator.
Great, thank you so much for that breakdown. We got another question here. That is, how should we collect cultures when we have an open system, such as syringes? Should we change syringes between putting blood first into the anaerobic bottle and then into the aerobic bottle? Do you have advice on this?
So there are studies that have looked at the value of changing the needle. So in some thoughts were that the needle may be contaminated, so remove the needle, replace it with a sterile needle, and then inject the blood culture bottles. That turns out, in my opinion, to be a very dangerous practice. And in the studies that have been reported, with almost no exceptions, they've demonstrated no value in changing that needle. So I wouldn't do that. Inoculation of the aerobic bottle, then the anaerobic bottle. I mean, that's the recommendations. I have never seen a study, it may exist, but I'm not aware of a study that has shown there is a difference between which bottles you inoculate first. In my opinion, and I emphasize this in my presentation, focus on the volume of blood you collect and worry about those other details a little bit less. I think also, as I said, try to be careful of not doing things that may be dangerous. It's an interesting concept, collecting specimens with a syringe. I said in my presentation, the optimum amount of blood is 8 to 10 milliliters of blood per bottle and 2 bottles per culture. That means you'd have to have a 20 ml syringe, but virtually nobody on the floors would use a 20 ml syringe to collect blood. So in my opinion, I think the use of syringes is now contraindicated. I think a needle set makes much more sense for blood collection.
Great. We have another question here that expands to diagnostic options for minimizing turnaround time. So the rate limiting step in detecting bacteremia is cultivation of bacteria from the blood. Even with some of our molecular technologies that have come out, he specifically is wondering systems like T2 biosystems of detecting organisms directly from the blood is one option that's tried to tackle this. But what's your experience in real life of trying to eliminate, or is it worth eliminating the cultivation step, or is there not going to be a way around that essentially?
I think we'll be real practical. I don't see blood cultures being replaced by any technology in the short term. We all hope that there'll be a molecular tool that will allow very rapid direct detection of organisms in the bloodstream. The challenges that we all recognize is that there's very few organisms circulating in the blood. So you need some way of concentrating those organisms in order to optimize your positive test result. I worked for 10 plus years with Becton Dickinson. We worked in this issue every day. And I think we all appreciated the fact that it's a real challenge. And I would say anybody, in my capacity and other companies would also admit the same thing. So our hope is that we'll have a new technology. I'm a bit pessimistic. I don't think we're going to see it in the near future, 5 to 10 years. I think there are culture techniques like T2, the example that you gave, is a complementary tool. I don't think it will replace the blood cultures, at least currently not yet.
Great, thank you so much for that input. One more question here. I think we'll keep chugging through these for as long as we can. So one more is, should we use PEDS bottles only for adult patients who we can't draw optimal blood volumes from?
Yeah, I think it's a challenge. If you introduce pediatric bottles and say it can be used for those particular adult patients, my experience is that they become the standard of care. And that really goes against what I talked about before, the importance of volume. It is interesting. We did a series of studies internally where we looked at what happens if you underfill a bottle. And it turns out that there's not a dramatic impact on that. So I would still use the adult size bottles for adults, even if you don't add the full 8 or 10 mLs, because we recognize certain patients you can't do that. Their veins collapse. They may be adults, but they weigh less than 100 pounds. It's going to be very difficult to collect the amount of blood that we're recommending. That's why I said that if you can only collect one blood culture, make it the best blood culture you can collect. So to absolutely optimize the result of that single blood culture. The recommendation is to collect multiple blood cultures, but do the best you can with what you're able to do. But I wouldn't use pediatric bottles in adult patients because I think it's just going to lead sort of to bad practices overall. And I'll just say, I don't look at prices or anything, but I suspect the cost of a pediatric bottle is about the same cost as an adult bottle. So unless I'm completely wrong, I don't think you're going to save money doing it that way either. So that's not a justification.
Yep, you're right about the cost. The cost is very dependent on if it contains resin or not, and both usually the PEDS bottles have resin as well as the adult aerobic bottles have resin. So those costs will be very similar. Thank you for that. Let me see if we have one more. You have received a lot of thank yous, so thank you again, Dr. Murray. There's one more interesting question I think we'll have time for, and then the rest of these we can respond to you directly using the email you registered with. So this one's really interesting. Since sepsis is basically a dysregulated host response to an infection, what role do immunomodulators play in the management of sepsis?
Oh, I'm not, Jordan, I'm not sure I'm the right person to answer that because I don't follow that literature carefully. It's actually too bad we don't have a physician that was on this call, because I think that would be more a medical question. I used to tell my fellows when I was training them, whether it's the NIH or wherever, that they don't practice medicine from the laboratory. You really have to see the patient, understand the patient to know how to manage that patient. So when they were always asked for medical advice, I said, never give medical advice unless you're going to go with a physician and see the patient. So that's sort of a modification of this. I don't feel comfortable answering that question.
Yeah, absolutely. Thank you so much again, Dr. Murray. I think that's all the questions we're going to have time for today. We really appreciate all your attendance and your involvement in the Q&A, and we look forward to any follow-up questions we might receive. And thank you again for attending. This presentation will be available on demand after this live session is complete, and you will receive a link to that in the email you provided. So thank you again, everyone, and feel free to forward that link to anyone who may have missed today's live event. Until next time, we hope we see. Oh, yeah.
Jordan, I'd like to also thank everybody. I enjoyed the opportunity. I sort of missed this. I did it for so many years. I hope that what we presented was useful. I always would sort of end my presentations by challenging the audience to take what they learned today and make one change, do one thing different than what they were doing yesterday that's going to improve what you do, whether it's what you do in the laboratory, what you do in the pre-analytical side, what you do in managing patients. But take something from this instead of just absorbing the knowledge and apply it to a patient and help that patient. And I think if you do that, then we've been successful in this presentation. So again, thank you to the audience.
Thank you so much, everyone.